We've gone over a bunch of different topics in terms of the issues with evolution, in terms of Lactobacillus reuteri, specific mechanisms that Wofgang reviewed, specific clinical scenarios. Hania gave me one of the busiest clinical schedules I've had in my morning session, and then Flavia opened it up in terms of possible therapeutic directions for the future. We have some time left over, so I'd like to encourage any questions that you might have. There's 2 microphones, or 3 microphones in the back. If you have any questions, please come and join us in terms of questions. It's the Brilliant Mind Studio, and it refers to everyone in the room. I'm sure there's going to be some brilliant questions as well, too. I guess while we're oh, here we go. Go to the microphone.
Thank you very much for this very challenging and updating session. I would like to ask a very specific question. I'm talking about horizontal gene transfer, which is a well-known survival mechanism for bacteria. And one for the evolutionary survival. And one of the many bad and good genes that are transferred between the bacteria in order to survive. There are very few publications about horizontal gene transfer in probiotics where they have transferred the antibiotic-resistant gene. My question, does Lactobacillus reuteri was a screen for some bad genes like antibiotic-resistant gene?
Okay, so the question's about antibiotic resistance. Who wants to
I can probably respond to this. Hey, Aaron, nice to see you, actually. Yeah. So to my knowledge, and we have people here in the audience who could tell me if I'm wrong, this Lactobacillus reuteri strain was screened for antibiotics, and it was actually specifically propagated to actually lose the genes that contain the antibiotic-resistant genes. So that strain actually is not resistant to any, at least therapeutically used antibiotics, and it does not possess the genes anymore. Is that correct? Yeah.
Yep. And,
so,
Hania,
and that was very specifically done to actually prevent any potential negative outcomes through horizontal gene transfer. Yeah.
So the original colic study by Savino in 2007, that's a...
The original study used ATCC, Lactobacillus reuteri ATCC, and I did not include it in our analysis. So I only focus on the studies which use Lactobacillus reuteri DSM 17938. Also, the original study by Francesco Savino was with Symeticon comparison in the comparison group. So again, it was different studies. So this is not included in the analysis which I showed you.
And my understanding between the different strains is the antibiotic resistance was removed as well too.
Yeah.
Very good. Okay. Second, thank you for your question.
Thanks first for the whole session. My question, what changes in the lifestyle which affect the population of L. reuteri? Is it the diet or a social behavior?
So at the moment we can only speculate. So we simply don't know. We've actually just had this discussion shortly before the session. If I would have to make a guess, I think it's probably something dietary, and there are 2 possibilities. It might be that through the increase of processed food that we have included certain food components such as emulsifiers, and there is some preliminary work from Ruth Lay group who showed that some specific fatty acid present in soy fat actually inhibit Lactobacillus reuteri, so there could be an antagonistic compound. And then something I think we should always consider is that we are eating very, very little dietary fiber and non-digestible carbohydrates in modern diet, while individuals in the past, and for example these Papua New Guineans, have studies with probably 100 grams of non-digestible carbohydrates from their diet, very rich in plant sources. So it also could be that we've removed the substrates, also the actual compounds that Lactobacillus reuteri requires to actually occupy a niche in the gut. So these are the 2, I wouldn't even call them theories at the moment or hypotheses. It's really just us speculating at the moment. And we are planning some studies to try and get behind this, but these studies have really just been initiated. Yeah.
Anyone else? No. Thank you very much. Yes.
I would like to ask about the promotility effect of the reuteri that starts 15 minutes after application. For how long does it last, and how often do you need to give it in order to maintain the motility effect?
Okay, so mechanism and dosage and timing. Wofgang.
Yes. So the onset is remarkably consistent in the different systems. It's around about 15 minutes. The duration is not so easy to assess, but it lasts for several hours. But after 2 or 3 hours, the effect on motility and the effect on pain fibers sort of decays exponentially. And the analogy, I mean, it's highly specific for the strain. So it's only this strain. We tried all sorts of different things, bifidos, salivarius strains, which don't target this pain receptor. But in whatever situation, it reminds me of antihypertensive medication. So, if you take ambulatory blood pressure measurements, when you take it in the morning or in the evening, blood pressure goes down, then rises again until the next dose. And so it looks like it's not enough to take one dose of this reuteri, and then you're forever set because it's colonized your gut. You never need to take another dose. I think it's probably not like that. It peaks within a few minutes. That's in contact, of course. It still has to go in vivo. When you take it, it still has to get there. So you have to take, how long it takes to get to particularly the small intestine, and then it'll decay. So, and then unfortunately you have to take another dose the following day.
And is there any evidence that it's a long-lasting effect, for example, from weeks or months, if you keep taking it daily?
Yes. Well, again, my best analogy is something like an antihypertensive. Yes, the effect is long-lasting. You sort of get a steady state, but when you cease, it'll again decay with a double or triple exponential. So it really has sort of a therapeutic effect based on physical laws, and there's a dose dependency as well.
Thank you very much.
Hania, did you want to comment also on the clinical dose and how you would dose that?
Well, in clinical trials, the dose which is usually used is 10 to 8, especially in the studies with infantile colic. And I think that the general approach is that in clinical practice, we should use a dose which was used in clinical studies to match the results that were shown in clinical trials. So this is what we should really follow. In the studies for the management of functional abdominal pain, it was either used once or twice daily. So again, one should have a look what is your population, which is most similar to the population used in the study, and then to use exactly the same dose in the study, which was a positive effect. In this V study, if I remember correctly, V, you are here, it was once daily, 10 to 8 once daily. So this is a study with a positive effect, which I already showed you, in children with functional abdominal pain. So if you want to have the same effect in clinical practice, so this is definitely the dose we should use.
Flavia?
Yeah, I would just to add something related to the effect of the doses once you stop. So there are some studies, especially the one in functional abdominal pain, that they saw the effect even after 4 or 6 weeks. Maybe I can say that the effect stopped average after 10 days, 12 days of stopping the therapy. So it's related to the therapy, the effect.
Great. I have a question. So Hania, you mentioned this in your presentation. This is Flavia's study, 2014 in JAMA, the use of Lactobacillus reuteri DSM-17938 for the prevention of colic, so not treatment, but prevention. Flavia, are you trying to put me out of business as a primary care pediatrician? So the question I have is that colic is very common, but not all kids develop colic. So in your study, you would have to have a large number of kids, but there would also be a lot of kids that wouldn't develop colic, but you're treating them. I guess your thoughts about that, Hania, if you have any thoughts as well too?
Well, we discuss it often with, very often with Flavia, and I think that research, Flavia, correct me if I'm wrong, that of course it's like a risk of over-medicalization of some of normal, I would say, event. So I think it's something that has to be considered. I think we both of us agree that this study, first of all, has to be repeated so that we are sure about the results. It's interesting. Flavia likes prevention. But again, the risk is of over-medicalization of some of the conditions. Colic is a good example. So this is something that has to be considered when we are making our decision whether to prevent or to treat this particular condition. But Flavia, I'm sure you can comment.
No, of course, I am agree with Hania. Again, we discuss a lot of time, not only with Hania, but also with other scientists. And this is the main risk of the study, to over-treat children that will never develop later. The problem, Mike, is now that in Italy, any mother wants to give and to supplement the baby until he birth, because they don't want to take the risk that the baby develop colic. So, and this is a serious problem to overtreat. That's why I agree absolutely for the repetition. I won't repeat. I mean, I cannot do again all the stuff, but of course I even cannot. And repetition for sure, and I don't know, it's just a matter of balance. There's, so far, has not shown any side effect for the overtreatment. So, I don't know, it's a discussion point.
Yep, no,
I cannot say the final word.
I just know as a general pediatrician, when mothers come to me, maybe their older child had colic and they're approaching that age, when they ask me questions, it's nice to be able to point to your study. So you've made my morning a little bit easier sometimes, but don't put me out of business.
But Michael, you want to make our life as scientists much more difficult, because if everyone is on probiotics, you cannot do any other studies, because one of the exclusion criteria is usually the use of probiotics. So please, be cautious.
It's not me, it's the mothers in San Francisco that are finding out
Mother
about
everywhere,
this. Yes.
everywhere.
Sure, super. Do you have any other questions? Yes, please.
My question is about the periodontitis or gingivitis, etc. We know that in rheumatoid arthritis there is a peptidylarginin deaminase that is citrullination proteins, etc. We are talking about post-translational modification of proteins. Do you think that the microbiota or dysbiota of the fetus is driving some post-translational modification of proteins, and premature delivery has some autoimmune background?
This is a very intriguing question, and thank you. For sure, preterm delivery, it's 80% an infection. The mother gets chorioamnionitis. So for sure, it's an infection for the chorio. If the other 20% could be autoimmune, maybe. Nobody knows, neither I. So for sure, one thing that I'm convinced, not only scientifically, but also philosophically, that a mother who is pregnant needs to be healthy, doesn't have to have any infection anywhere in the body, neither in the mouth or in the leg or whatever. Doesn't matter, because the womb is not an isolated environment. It's impossible. Of course, we have all the technicians, as maybe Jen said, that there is a control of all this crossing the placenta, but you are not isolated. Look, we are thinking about this blood-brain barrier, but they discovered the brain as a lymphatic vessel. So maybe it will come that there is a lymphatic vessel around the placenta and something can cross. So maybe that 20% could be autoimmune. For sure, now we have a chorioamnionitis in the 80% of the preterm delivery.
Good, great. Any other questions? Flavia, I'll give the last word to you. Do you have any announcements
just
to make?
thank you, BioGaia, for giving me this opportunity. I invite you all, next edition of Probiotic Prebiotic in Pediatric in Bari 2018, April. Maybe we will have some answer, more detailed for you. Thank you.
Okay, thank you very much. Thank you.
Very good, thank you.
Thank you.
Thank you. That was a pleasure. Thank you, Michael.